Association for accepting wholeheartedly to conduct this 68th International Virtual Learning Series with the blessing of Almighty. Our founder, Vallal Devathir Kalasalingam Ayya, with the support of our chairman, Ilaya Vallal, Dr. S. Sridharan sir. I am here to deliver the welcome address for the 68th International Virtual Learning Series. Can you hear? Can you hear? Andu sir?
Yes, sir. We can proceed, sir.
Titled on Community Pharmacist Contribution in TB Management Process in Vietnam, Standardized Patient Survey. In the association with the Indian Pharmaceutical Association, South Tamil Nadu local branch, head office at Arulmigu Kalasalingam College of Pharmacy. Today we are proud to have an eminent scientist, notorious researcher, distinguished personality, and honorable resource person, Professor Dr. Shukry Zawahir, Department of Sydney School of Medicine, Faculty of Medicine and Health Sciences, University of Sydney, Australia. It is a great honor to have with us for this occasion. We thank you for kindly being the valuable part of this wonderful session, sir. Let me acquaint you with the sterling quality of this eminent personality who is a brilliant researcher. Sir, your prestigious presence, it is a great honor for us and great motivation and inspiration for our students. Sir, we are fully appreciate you for finding the time to be with us despite of your busy schedule, sir. Most welcome, Dr. Shukry Zawahir, sir. Most welcome you, sir. Zawahir, sir.
Thank you. Can I proceed?
Yeah, wait, sir, please, sir. Finally, I welcome all the professor, faculty members, and my dear enthusiastic students for today's session. It is gratifying to note that this session covers a wide range of interesting topics relating to the community pharmacist. So I hope this session will be a good platform for us, for our students. Dear students, kindly utilize this great opportunity to explore your knowledge. This is the first and foremost needed for your career. Once again, I welcome you all the very best, my dear students. Thank you. Thank you, sir.
Thank you so much for kind introduction. It is my pleasure to be here in online platform to discuss some of our research experiences and work experience different developing countries. So though I am from Australia, but still I am a Sri Lankan. I did my PhD in Australia and continuing my postdoctorate research in Australia. So I do speak Tamil. Vanakkam anevarukkum. And some of the colleagues from Sri Lanka, Aiborn, and those who are joining from other countries, good morning and welcome to this session. And thank you so much for having me here. So in this particular session, I thought of discussing some of our current research we have been conducting in different countries, particularly in Vietnam, as a huge group of scientists, researchers throughout the world, including Australia, Vietnam, Sri Lanka, Philippines, and so many other countries. So this is actually very particular for pharmacists, and especially for pharmacy, community pharmacists. I hope, can you hear me very well?
Yes, sir. No issue, sir.
Okay, good. Thank you. All right. So overall, I would like to discuss my throughout this discussion session in three main themes. This is not a research objective, but theme of today's topic or broad objective of today's topic. Actually, I want to emphasize importance of pharmacy practice research, especially in this era. And also I want to emphasize something, importance of pharmacist contribution in outbreaks or pandemic like this COVID-19 pandemic or this situation, how a community pharmacist or pharmacist could contribute to mitigate these kind of issues throughout the globe. Also future opportunities for pharmacists in contribution to the research and in the scientific world in order to have better healthcare system or contribute to better healthcare throughout the globe. So most of the time people used to think like pharmacist is a person who is handling clinical cases or clinically in the hospital or dispensing in the community, but we should understand a pharmacist could do much more than that, especially in this kind of situation where the pandemic or outbreak occurs. So since my topic is TB, most of you may be aware of this background of the TB. So though
you haven't shared your presentation.
Sorry?
You haven't shared your presentation, sir.
Not shared?
Not shared, sir, not shared.
Hold on.
We can see you only.
Oh, sorry.
No issues.
Oh, sorry. I thought it's already shared. Okay. Can you see this one now?
Yeah, yes, sir. Yeah.
Okay, sorry about that. Okay, you could have told me earlier. Okay. Can you see me? Can you see the slides now? All right. So I'm just want to start giving some highlights about TB. As all we know, the TB is one of the old diseases. Last couple of 100 years it's been there in the world. But early days, the cause of TB was unknown until March 1882. What happened in 1882? Dr. Robert Koch, he discovered the bacteria causing the causative agent of the TB, that is Mycobacterium tuberculosis. So after this discovery, after his discovery, then the people get alerted and started researching more and more about TB. Normally, as we know, the TB bacteria or TB pathogen is transmitted through air by, when a sick patient is coughing, then it can be transmitted to other people. And mostly the TB pathogen affecting the lungs, also some other part of the body. But effective treatment for TB was not discovered until 1940s. Then later in 1940s, the TB treatment was introduced, and then people started using and doctors started prescribing TB treatment to the patients. And meantime, the TB vaccine, BCG vaccine for TB patients or preventive vaccines was first introduced in medical world or first used in the medicine in 1921. But there's so much story behind the vaccine. Earlier it was introduced, and then later stopped, and then later, 1921 start using medically. So there was some, discrepancies between the countries about TB medicine use. So if you look at the problem related to TB, actually TB is one of the preventable communicable disease, but affecting globally. It doesn't matter it's a low or middle or poor or low income country or high income country, doesn't matter. It's still the TB is affecting everywhere in the world and transmitting. And TB has been identified one of the 10 leading causes of death globally. It's one of the main leading causes of death. The global estimation of TB morbidity, TB incident cases in 2018, this was from a report, WHO report last year published. So the morbidity is 10 million people last 2018. 10 million people, new cases actually. This is not a simple thing. And then if you look at the statistics, the 10 million or close to 10 million other years like 2017, 16, close to this every year, the incident cases of TB. And of course, with the TB management, especially if the TB occurs due to MDRTB, multi-drug resistant TB, then the cost of healthcare is going to be massive and and it is not bearable for, especially for countries like Vietnam, including India, is very costly. And I'm sorry about this slide. You may not be able to read these figures, but I just want to highlight, as I mentioned earlier slide, that the TB incidence in 2018, according to WHO report, is very high, and WHO listed 30 TB high burden countries, that including India and Vietnam. So if you look at the incident, Vietnam here 182 cases, incidents or new cases in 2018 out for 100,000 population. And the Indian cases, new incident cases of TB, more or less same to Vietnam cases. So it is a huge problem, and WHO recognized India, also Vietnam, are two of the high burden 30 countries identified. So this slide shows very clearly, like this is Vietnam, you may know, and as you know, this is India. So India and Vietnam, 100 to 119 range, like incident cases for 100,000 population per year, especially this one. This figure comes from 2018 WHO report. So it's more or less 100 to 199 incident cases of TB, and it is similar both countries, Vietnam and India. But with the TB, there's some other issues making the TB cases more dangerous. What is that? Actually, if it is TB alone, it can be treatable, yes. But the TB cases will be more severe if TB associated with HIV/AIDS or MDRTB, multi-drug resistant TB. So this is again from WHO report 2019. So they try to triangulate the cases POTB, which are the high burden countries having TB alone, TB with HIV, and multi-drug resistant TB. So if you look at India, India comes to, in both cases, multi-drug resistant TB and TB with HIV. So one of the countries affected by these two types of TB is India. But when come to the Vietnam, look at here, it is like Vietnam is having problem with the multi-drug resistant TB as well as the presumptive or TB cases. So TB itself a problem, but people, when come to the multi-drug resistant TB and HIV TB is going to be much greater problem than a TB cases. How people get multi-drug resistant TB? One of the main reasons for that is inappropriate management, poor adherence to TB therapy, or poor compliance or adherence, and inappropriate management. So later part you will understand how we can understand how inappropriately TB patients are treated. So since this study is based in Vietnam, so I would like to highlight what are the issues in Vietnam related to TB. As I told you earlier, Vietnam is one of the 30 countries recognized by WHO as high TB, high burden countries. Also commonly occurs with multi-drug resistant TB. And it is estimated like last year or more or less every year, new cases or incidence estimation is 182 cases for 100,000 population in the country in Vietnam. But main problem with MDR-TB is delays or unwanted or unnecessary delays in diagnosis and starting or commencing the TB management in Vietnam. These are the reasons for high number of cases, especially MDR-TB. If you look at this graph from 2010 to 2018, the MDR-TB cases detected is increasing dramatically. So a total number of MDR-TB cases, also treatment according to the number of cases, the treatment also increasing. So the MDR-TB problem is there in Vietnam. This graph also I took from WHO report last year. So can you assume how many MDR-TB detected? I mean, over the last 2009 to 2018 in what do you call in India. Like in 2018, India multi-drug TB cases is 60,000. So the problem is much greater than Vietnam. In Vietnam, it is around 3,000 actually in 2018. But in India, it is 60,000. So multi-drug resistant TB is one of the greatest problem in India as well. So if I ask the question, which healthcare providers are most accessible and able to educate the patient and screen for the TB cases? Most of the time, is that everything okay? Can you hear me well?
Yes, sir. Yes, sir.
Okay. So if I ask this question, most of the time, I hope everyone's, including myself, if I ask the first time, that come to in my mind is most appropriate health professionals are nurses and doctors or physicians, because we know mostly these are the people, health professionals are involved in TB management. How about community pharmacists? Can a community pharmacist can contribute in the management process of TB? Could you think of it? Yes, of course. How? I'm not talking about here, appropriately dispensing TB medications to the patient. That is part of general role of a community pharmacist. That I'm not talking about the dispensing part of the TB medication, but in the TB process, how significantly, or in the TB management process, how significantly these community pharmacists, especially in developing countries or low and middle income countries, could contribute to mitigate or eradicate TB from the country or rural settings. What is the beauty of community pharmacies actually? As compared to other health professionals, the community pharmacies are being open long hours, so the people can access easily. More convenient to patients, because most of the time we can find community pharmacy all around the villages, cities, and everywhere. And the distance from home to the pharmacy is much lesser. And if you go to community pharmacy, of course, waiting time is much lesser than to go to a hospital or private clinic or something like that. And one important thing, researchers found that in high TB burden countries, patients often seek healthcare support from community pharmacists first before going to a doctor. So this is the crucial part coming, and this was reported in many studies, including last year one systematic review. So in the high TB burden countries, including India, Vietnam, and many other countries, these TB patients or presumptive TB patients seek help from the community pharmacies at first. And then based on that, they will go for further diagnosis and treatment. So this is the crucial part. We can play around in order to help our health professionals, other health professionals, also contribute ourselves as a community pharmacist in order to have proper involvement in TB management process as a pharmacist. Now, this is again from WHO 2018 report. Here, delays in TB identification. You know, one of the Vietnam is here, the middle-sized dot. So the Vietnam is one of the countries having large gap in identifying new cases, also relapse cases. So there's a gap in identifying the new cases, new TB cases, also relapse cases of TB incidents. So this is the problem with Vietnam and also India. India also a huge problem. So these are the issues in the community. You know, they are not able to identify these cases early enough, right? If we don't identify TB cases, what will happen? We know, like, you know, contact tracing is very common now in this period because of COVID. You know, every country, every health system, they are talking about, you know, identifying the index cases. From that index cases, how we can go further and trace the contacts in order to isolate or start treatment, something like that. So we are very well known about these contact tracing or delays in diagnosis. So in COVID situation, we are, you know, working very hardly to identify these all contacts. How about in TB cases? If there is any delays in management or you know, identifying the cases, then what will happen? As COVID, they will spread the symptom, spread the condition or TB to other family members in the village, in the community. So cases will be increased, and there will be delays in case detection and also diagnosis, and uncontrolled spread will be there in the community. And in this case, now if they, you know, if they don't identify or detect these cases, then, you know, they keep on taking some other medication like cough or other antibiotics, then that may cause multi-drug resistant pathogen development, so that the normal TB treatment may not work these patients. So the crucial area here I want to highlight delays. Now, two things I'm highlighting. One is in the community setting, TB patients, I mean, they don't know still they have TB, but they approach community pharmacists for support. Second one is that in the community, there's obvious delays in detection and initiation of the TB management in the community setting. So again, a systematic review, also WHO reported, if community pharmacists could able to detect these patients who are coming with a chronic cough, this and that, I mean, with the TB symptoms, and then appropriately guide them, advise them to the TB centers or hospitals or further healthcare screening, testing, and starting the management. So the community pharmacy should be able to understand, identify these cases, and appropriately refer these patients to the healthcare system in order to screening and further diagnosis and treatment. If community pharmacists failing to do so globally, each year 3.6 million or 36% of the TB cases, incident cases, will be missed from initial or delays in initial treatment of TB. then that will increase the number of new cases because of spread in the community. So what I'm going to emphasize here, by contribution of the community pharmacists in TB screening process or identifying TB cases, we can minimize 36% of the global initial TB incidence. So this is 1/3. It's a huge contribution from the community pharmacists. So first thing we have to understand as a pharmacist, are we ready? Do we have enough understanding, knowledge about TB or any outbreaks? So these are the things you have to have quality pharmacists in order to have better practice. So if we have quality pharmacists with better understanding, they can contribute in the community. And now the world, including WHO, having goal by 2030, we are going to stop or eliminate the TB from the world. So we will be contributing 1/3 of this elimination process. So as a pharmacist, this is your target year old. So the same thing happened in Vietnam. A previous study with 138 pharmacies in Hanoi, the capital of Vietnam, found 46% of simulated TB suspect patients were referred to further diagnosis and 41 received antibiotics. I mean, this is alarming again. Simulated or pseudo patients with the TB symptoms, when they go to the pharmacies, only less than half of them refer appropriately to the TB centers for further diagnosis and treatment. And 41% of these patients or pseudo patients or simulated patients were given antibiotic. That is wrong. But however, we did not find any national study. This was small sample size in one province only. But we did not find any national study to address this issue as a whole in Vietnam. So as a team of researchers from different countries, including Vietnam, government of Vietnam, Australia, and some other countries, we plan a study aimed to determine the pharmacists, especially community pharmacists, contribution to improve detection of presumptive TB cases by referrals in Vietnam. So how these pharmacists, community pharmacists in Vietnam could contribute in early detection of presumptive TB cases, because we already identified in this previous study, we can say it's a pilot study, almost half of the patients were not, more than half of the patients were not, or TB presumptive patients were not properly referred to the healthcare system for screening. So we want to understand as a whole in the country how it happens. So in our particular disease study, we had 3 main objectives. First is detecting and appropriately referring the presumptive TB patient, whether the pharmacists are detecting these cases and appropriately referring these patients to the healthcare system, TB centers or hospitals. Also, the second objective was the pharmacist's behavior in terms of medical history taking about the reported symptoms, and then advising the patient about the TB and appropriately guiding them to proper healthcare system. Also factors associated with TB referrals. So these are our objectives now in the study conducted in Vietnam. Actually, this study was conducted in 2 phases. Phase 1 was mapping part of the study. The phase 2 was Standardized Patients Survey. So first we mapped the areas. We selected 4 provinces in Vietnam, 2 in northern Vietnam, Hanoi and Thanh Hoa, the 2 in southern part of the Vietnam, and that area covers about population about 20 million, about 15 million people. So in this area, we mapped the pharmacies. Why? Because most of the studies in community setting, what we do, we rely on government statistics or addresses or government details. But most of the time, if the pharmacy is not registered, then we may not get this information. sometime in the rural settings, if pharmacy, every year in Vietnam especially, they have to renew the registration every year. If they delay, if the pharmacy is delaying in terms of renewing the registration, then their record will not be in the system, in the government system. So we thought, like, irrespective of whether it's registered or not, we have to identify all the pharmacies. So we did a mapping study. We mapped all the pharmacies in our study area. And then as second step, based on the mapping, we understood now this much of pharmacies are there. And then we did our standardized patient survey. So you all may be aware about this. What is standardized patient survey? It is actually one of the robust method currently we use in health behavioral studies, mostly in developing countries. Actually, this kind of study widely used in commercial setting or business or promotional or commercial setting, but it is now currently widely started using these kind of studies in to look at the behavior of the health professionals. So we thought of this is the best study to understand how the pharmacy staff behave with the TB patients. Actually, the other way around, if we go and ask pharmacy staff and say, for example, as a questionnaire based, like cross-sectional questionnaire survey, we ask, do you refer these TB patients to healthcare professionals? They would say yes, because they know this is a study, so there will be a social disability bias. But in this particular study, we call SPS, Standardized Patient Study, we train the actors, or we call standardized patients. We train the standardized patients as a patient, and then they go and report as a patient, and we observe how the pharmacy staff react to these scenarios. So again, so this kind of study, number one is free from social disability bias. The second one is free from Hawthorne effect. Because if they know somebody is being, they are being observed by somebody else, then their behavior may change. So what we did, without informing them, we just go and act as a patient and see the behavior. So this is a kind of robust study to see actual behavior of the pharmacy staff in this particular situation. Many studies reveal that they compare, like for example, even in Sri Lanka, we did one study, same but viral infections, how people are treating viral, pharmacists are treating viral infections. So what we did, we just went to the pharmacy and reported symptoms of upper respiratory tract infections, and we see how they react, whether they are giving antibiotics and all. After that, immediately we went, some other people, in our research, went and asked for the survey. Do you, dispense antibiotics, something like that. We found a significant high amount of the pharmacy staff, they say they will not give antibiotics for viral infections. But in the SPS visits, we found more cases they actually gave rather than reporting. So this is the problems. To eliminate the social disability bias, we did our SPS study. Now we have, this is the Vietnam. Vietnam is a long country. So, and the north and south, why we selected this different region, because north and south are very different in terms of their accent of the language and many things. So we thought of having north more on urban and then south more rural again. So we purposely selected two provinces from north and two provinces for south, and we mapped the facilities of pharmacies. So in the SPS process, so now from this point onward, I will use the term SPS. SPS means Standardized Patient Surveys, right? So I hope you have clear understanding what is Standardized Patient Survey. So we developed this Standardized Patient Survey based on previously conducted studies, including one of the studies in India. And we trained the standardized patients. That is crucial part of the study. We have to train them as as a patient, and if you have different actors acting, everybody should act same way so that the acting will be appropriate. Otherwise, if everybody is acting differently, it's going to be a problem. So training is very crucial part in SPS surveys, and sampling, data collection, and data analysis. So in our study, actually we developed two scenarios, SPS scenarios. One is presumptive TB scenarios, and then multi-drug resistant MDRTB scenario. And in the presumptive TB scenario, we had we trained our standardized patients to go and report like they are having 2 to 3 weeks of cough, fever, loss of appetite, and weight loss. And by reporting these things, then the pharmacist should be triggered like there is some problem, chronic cough is there, fever, weight loss. So then immediately they should ask further question about their treatment and this and that related to this one. And then without giving anything, they should have refer these patients to hospital or TB center for further screening. And second, we visited 320 pharmacies. These pharmacies are different from these, not the same. And all these 4 provinces, we reported 4 weeks of cough, fever, weight loss, history of unsuccessful TB treatment. It means like previously this patient had a TB, and then after two months of TB treatment, he found his the tests are clear or positive, so he stopped the TB treatment. And after 2 years, he's having these chronic cough, fever, weight loss, and all these things. So this is clearly triggering relapse case, most probably MDR-TB. So in both cases, the patient should be referred to a healthcare system in order to screen for the TB, and if it is managing TB management. And in all situations, like we train our SPs in 3 levels of request medication. For example, if they go and just report, and if pharmacy staff gave any medication other than antibiotics, they ask for a stronger medicine, that is level 2. If pharmacy staff is still giving some other medication other than TB medication or antibiotics, they ask for antibiotics. So this is kind of pressurizing pharmacies, whether external pressure or patient pressure influence the behavior of the pharmacist. We want to identify this one. So we thought of having 3 levels of demand of medication for TB cases. So based on that, our appropriate referral or primary outcome was, in both cases, both scenarios, patients should be, or standardized patients should be referred to healthcare system, hospital, or TB center without giving any antibiotics or steroid or any medication. This was our primary outcome. So in the process of this study, we recruited the study team or researchers, both north and south part of the Vietnam, and we trained them separately because as I mentioned earlier, their language, accent are different from each province. So our main purpose is, why we are doing, because if the pharmacy staff detected these cases or these SPs, standardized patients, they are not real patients, then there will be a problem because their behavior is going to change. So because of that, we wanted to have local people. We trained them over 4 days, and we used standardized manual for training. And then after training, we did some pilot visit with them, other than study area, to see whether these people, these actors well trained and they acting as we expected based on our manuals. So these are some of the training sessions we conducted. We did some training and then discussions, role plays within the classroom setting. And then we trained them how to fill the questionnaires and also kind of qualitative recording. and how to label the medicines, how to label the recordings, and at the end, a team leader, how he or she should enter the data to the REDCap database provided by University of Sydney. So here I would just want to highlight this thing, qualitative recording. So this is the part of, in the process of the visit, we ask our actors always, in each interaction to the pharmacy, an actor or standardized patient and an observer went to the pharmacy and interacted. The actor only interact, observer was observing what is happening. Immediately after exiting from the pharmacy, they have to go to a quiet place away from the pharmacy, and they had to fill the standardized questionnaire based on the visit. And then they also need to discuss the qualitatively record that about the visit, how was the pharmacy, what is the size of the pharmacy, and how many people were there, whether it's crowded, this and that. I mean, what is the situation which were not covered in the questionnaire? So they record immediately, at least 15 minutes after the visit. So this is some of the pictures we took during the pilot visit. So the researchers or research assistant, they went to the pharmacies and then collected and came to a roadside, and then how they fill and how they record and how they check all these things. So this is all the process. So, and after that, we have randomly selected the pharmacies for these scenarios. And the main thing we did, one scenario, that is presumptive TB, were visited by one set of the pharmacy, randomly select pharmacy by one set of standardized patients. And other scenario were visited with scenario, different set of actors and different pharmacies. Because, again, we wanted to have, avoid any kind of suspicion. And then we analyze the data descriptively, and we use some chi-square t-test, multiple logistic regression using SPS version 24. Right, this is the interesting part. Yeah. Now, as I mentioned earlier, we want to have the primary outcome was all these both cases, like presumptive TB, also MDRTB cases, should be referred to the healthcare system without supplying any medication, including antibiotics or steroids. But in case of presumptive TB, only 12% of the staff, pharmacy staff, refer these SPs to the healthcare system. And the red bar shows the appropriate referral. Appropriate referral means they refer the patients or SPs without giving any medication. But in this case, they refer, but still gave medication. And then if you look at the MDRTB, it's much better, because 1/3 of the patients were SPs were referred, and then appropriate referral 21%, better than presumptive TB, but it's still low. We expect more than 50% should be referred to the healthcare system. And unfortunately, we found like 90% of these SPs offered antibiotics for short term, mostly 2 to 3 days, something like that. And with a clear MDRTB, around 70% of them receive antibiotic for short term again. So this is alarming issue, because why? Giving short-term antibiotics will mask the TB symptoms. Even if they go to TB screening, that may cause some problem in detection of TB cases. Also, patient may feel some comfort, and patient may not go to hospitals soon. In that case, patient keep on spreading the TB to the community. It's an alarming problem, right? Then if I look at the other medicine or medication supplied, actually you can see here polypharmacy exists. I mean, both cases median number of different medicines supplied for each interaction, each pharmacy visit was 5. And the interquartile range was 4 to 6, is high. The same thing with MDRTB, like they're bringing 4, 5, or some cases 7, 8 medicines. This is really alarming. And total, we received with a presumptive TB visit 1,475 different medicines. Out of that, antibiotics was there, steroid was there, and even anti-TB antibiotics also were there. Same thing happens with MDR-TB, antibiotics, significant interactions, steroid, and then anti-TB. Again, giving steroids for TB patients in both cases is contraindicated. Giving is really problematic. And giving anti-TB medicines or anti-TB antibiotics for TB patients is alarming again, because TB medications are kind of rare medications. If we give these medications to the TB patients, especially they are giving like 2 to 3 days, not proper course of TB medication. If you are giving like rifampicin and all these medicines, if they give, then the chances of developing drug-related or drug-resistant pathogen is high. Then the patients ended up having multi-drug resistant TB, and then they will spread these multi-drug resistant infection to the to other people in the community. Is alarming. So there was a huge problem. And if you look at this, I just want to highlight some of the medicine, like, they give just one pack like this way, maybe you can see for 6, 7, 8, or maybe more than that, they asked to take this pack at a time, something like that. So different medicines were given, more than 4, 5, 6 medicines were given. And then we look at the antibiotics, which are the antibiotics given to these patients, how they were given, how many. And most common antibiotics given for presumptive TB were cephalosporins, and then penicillin, quinolones, and macrolides. So the same thing goes with the MDR-TB cases. So again, giving antibiotics is a problem. Giving broad spectrum antibiotics also a huge problem. Also, you may know that these antibiotics like cephalosporin, penicillin, and quinolones are one of the WHO categorized these medicines are high priority, critically important antibiotics. It means these medications should be preserved. We can't commonly give to everyone, including doctors. Doctors should, if they identify these patients, when they are prescribing, not to TB, but any other bacterial infection, when they are prescribing, they have to think twice before prescribing these medicine, because this is some of the highest priority, critically important antibiotics. So, but unfortunately, pharmacists, without any proper diagnosis, they just gave out these medications to the patients, or presumptive and MDR-TB patients. That is alarming. Again, we can conclude, or we can assume this will contribute towards ABR, antibiotic resistant, including multi-drug resistant. And as an appropriate community pharmacy practice, we expected pharmacists to ask more questions about reported symptoms. So medical history, fair number of cases were asked, or the SPs were asked about reported symptoms, and then also they were advised, the SPs were advised how to take and how often to take these antibiotics when they were supplying antibiotics. But unfortunately, only 10% of the presumptive TB and 21% of the MDR-TB cases were receiving kind of advice when to stop taking antibiotics. But I want to emphasize one thing here. Giving antibiotic is wrong. But again, giving antibiotic without proper advice, it is also making the wrong more worse. Right? In this case, like, when to stop, nobody advised, or very few people got advised. Now we want to understand, now, the certain number of people were referred, and what is the factors? What are the different factors influencing their referrals, right? Then we went for kind of regression model, logistic regression models, and we put all the possible factors could affect their behavior in terms of referring the patients to the TB centers or hospitals. And we found people in southern region in Vietnam, in the adjusted model, more likely to refer these patients to the hospital or TB centers. The same thing goes with MDRTB cases. And in terms of medical history, those pharmacists who took medical history, they're more likely to refer these patients to health system for further analysis. And rural people, rural pharmacy staff more likely refer these patients than urban. So that is significant only with a presumptive TB. Now, two things I want to highlight here. Pharmacy staff, those who has knowledge about their practice, if they have knowledge, then only they ask more questions or medical history. So with a knowledgeable pharmacist who asks more questions about that, they understand the case and they're more likely to refer these cases to the healthcare system. Though this is not significant, but it's a positive trend. And we found like one region has poor practice than other region. So from here I can understand that there's a regional issue in enforcement of rules or regulation, right? So because in Vietnam, giving antibiotic without prescription is illegal, but they have without referring these patients to the healthcare system, they simply gave antibiotics and other medication. So again, the South pharmacies have some issues. So I want to explore further why South is North is behaving. South is behaving better than North, something like that. So I did some demographic characteristic of the pharmacies, and if you look at this pharmacy registered and unregistered, in South, most of the pharmacies were registered, but in North, most of the pharmacies were unregistered, almost 90. So here, registered pharmacies, South. So I'll go back to this slide. South pharmacies are acting very well, and those pharmacies were registered. So I got the now answer. Registered pharmacies were acting correctly than unregistered pharmacies. Of course, if they want to register their pharmacy, they have to follow the regulation, and a pharmacy should be there. So most of these things should be followed, but unregistered, they don't care, they just do the business. So the legal issue or enforcement of the regulation should be emphasized. So from these findings, these are some of the key finding I want to highlight from our study. The number one, the appropriate recommendation to refer these patients, SPs, to the healthcare system is very poor in Vietnam. Can you remember that one is 12 to 5%? And high proportion of standardized patients or SPs receive antibiotics without a prescription. Receiving antibiotic without prescription illegal according to Vietnam law. Second one is inappropriate because antibiotic won't help. Short-term antibiotic without anti-TB antibiotic will not help these TB patients. And then pharmacies in southern Vietnam were more likely to refer the patient because those pharmacies are registered. And if those staff has knowledge, they took patient history so that they understood the case, they're more likely to recommend these patients to go to a hospital or clinic. And as I mentioned earlier, these are the strength of our study. Actually, this was a large cross-sectional study. we covered both region, south and north. So we can validate and understand the problem in different region of the country. And we selected the pharmacy randomly and then select the scenarios, these pharmacy randomly. And the SPS approach, as I mentioned earlier in the method, in the early method part, approaches to understand the pharmacy referral, which avoid the social disability bias and Hawthorne effect. So if you do any other kind of surveys, we can't get rid of these kind of bias. So whatever this finding may be highly validated than self-reported surveys. But of course, we have some other limitations as well, because we had about 32 actors or standardized patients. They were acting in 2 different regions. So though we trained them for over 4 days and then send them for pilot visits and all, but still based on interpersonal differences, they may act differently. So according to their action or their interaction with the pharmacy, the behavior may change. But we took a high responsibility in terms of training. Also monthly we visited with these patients, with these standardized patients to the pharmacy to see whether they are acting appropriately. And the other thing is we train them and then ask them to act according to our scenario and the manual, so that they can't speak beyond that. They are kind of restricted. Actors are restricted to talk only certain things. So that is of course away from like normal patients. No, as you know, if a normal patient, if he goes to a pharmacy, and then the patient can freely talk, pharmacists can ask any questions. But in this case, they can't talk because we want to standardize. We can't just let the actors to talk anything. So in that case, the behavior of the patient may differ from actual case. And whatever the reported is exclusively from the actors and observers. So we have to rely on their reporting. But there should be no bias for them to report wrongly. So and the other thing is we could not identify the professional qualification of staff interacted with us. We don't know whether the person who was interacting with us were the pharmacists or some other people working in the pharmacy, because if we ask, are you pharmacists, that is kind of make suspicious. So we didn't have any way how to identify whether the person who is interacting with our staff was a pharmacist or not. As a conclusion, now this is the problem. In pharmacies are not contributing TB management. How to contribute? As I mentioned earlier, if they can refer these patients, understanding the cases, and refer this patient appropriately to the healthcare system, then they can help in early detection. So pharmacists should be, should contribute in the future in order to refer these patients to a healthcare system. And particularly in Vietnam, the geographical variation impacted their behavior. And then also, supplying broad spectrum antibiotics, including anti-TB antibiotics, may delay the appropriate TB treatment and contribute to acquired drug resistant or multi-drug resistant problem. So if pharmacists can behave correctly, we can eliminate the TB, 1/3 of the TB cases from the world, And then if they keep giving antibiotic in the future too, then there will be a problem of helping them in delays TB treatment, also contributing MDRTB cases. So that we recommend, this study highly recommend regulatory enforcement of antibiotic supply in the way of antimicrobial stewardship. We have started already. We are now working on intervention phase of this study. We have developed few training programs, manuals for pharmacists, pharmacy students, So they need to follow, they need to understand, so that in the future they will react correctly. And then we have started this, another recommendation from our baseline study is professional training for pharmacists. So this is one of the things we have to, currently working pharmacists. In Vietnam, there are different types of pharmacists, pharmacy with a diploma and then degree holders. So we have developed different manual for them to improve their knowledge and professionalism among them in order to pharmacy practice. So with that, I would like to acknowledge all the team members. These are the Vietnam investigators working with us. And then one of the institution we collaborated, Vietnam Woolcock Institution. So these are the people from Woolcock, and these are the Australian collaborators. In these projects, I was a postdoc and handling this project. And then also we were supported by Australian government and University of Sydney for this study. And with that, I would like to thank everyone for patience and listening my talk today. And thank you for this opportunity. And yes, and if you have any further questions, further things, I'm happy to discuss further. And if any suggestion, please, you are welcome. And thank you so much for your patience and listening to this talk. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir. We had a wonderful and informative presentation, sir.
Thank you. If any students, anybody has any questions, please, or any suggestions, please welcome. We are in the process of writing the paper, and most probably we are submitting this paper to what you call BMJ Global Health soon. So it's almost ready. Yeah.
So good morning, sir.
And don't feel free to speak Tamil, Hindi, Sinhalese, or whatever language I can understand. I can talk these languages. I can even talk Hindi, Tamil, yeah, and Sinhalese. Yes.
Yeah. Good morning, sir.
Yeah.
Sir, you are from Sri Lanka.
Yeah, correct.
You are doing your postdoc and PhD in Australia.
Yeah.
Then why you have choose the Vietnam as a study site, sir?
Very good question. Yes, this was a grant study, right? So the Australia government is supporting this study. There was a grant call to see health security of the region, Asia Pacific region. So we thought of, Vietnam is a region. So we have started doing this study, not only this antimicrobial stewardship study and this study, TB-related study in the region because of the grant. So we have our study running in Vietnam, also Indonesia. These are the neighboring neighboring countries. Australia want to support this country to do research, not Sri Lanka. But in my PhD, yes, I did studies related to antimicrobial stewardship in Sri Lanka. So I have completed my PhD. Now I'm a full-time postdoc working on different projects, especially in Vietnam, and another postdoc working in Indonesian project. Yeah. So all because of the grant.
Okay, sir. Thank you, sir. Sir, regarding statistics, if you see the statistics, India is one of the most affected country.
Yes, of course.
But Indian immunization, if you see the Indian immunization schedule, and most of the born people after 1990s, they are exposed to PCG vaccination.
Mm-hmm.
Even though that immunization, why there is a high ratio of tuberculosis in India or in the most in the developing countries? I think I thought so. Most of the developing countries also practicing immunization schedules.
Yes. The problem is, immunization should be, if you look at the literature, immunization or vaccine development is still in the process. Yes, BCG vaccine is there, but now we are in the era of not original TB, right? The TB pathogen has been changed. Now the multi-drug resistant TB pathogens are there, but we are using the same BCG. It was invented 2020. So if the patient is infected by pathogen that is resistant to basic these things, I mean, the resistant to antibiotics and all TB treatment, but the vaccine is originally developed for original pathogen. Now pathogen has been changed, muted. So now if you look at this literature and all this, there are so many research going on how to, I'm not telling don't take BCG. That may help in some extent, but now no more like, original, the people are not infected by original one. It's a muted versions are there now. So we need more new vaccines, new vaccines to vaccinate for the children in the future. But there are a lot of research going on. And as I told you earlier also, when this BCG was introduced, there was a very big conflict. UK started using it and the US banned the vaccine. They said there's no proof of effectiveness, this and that. Later part, something is better than nothing. But they found some evidence to support this is effective. But we can't ensure 100% effective because of the changes all the time.
And if we see that statistics, most of the developing nations is getting affected by TB, not the developed nations.
Yeah.
So if there is any socio-economic factors influencing the rate of spread, sir?
Yes, my understanding, the number one is developed countries, for example, in Australia, for example, now COVID case I'm living in Sydney, New South Wales. When they found a case, one case, what they do, they have enough money to spend. They try to trace all the contacts related to this case, and then they ask the people, then they spend a lot of money for contact tracing, and then ask these patients to, or these contacts to self-isolate or force self-isolate. So same thing with these cases like TB. If they identify, there are a few cases in Australia as well. There are cases, but when they identify these cases, they handle very well. But in low and middle income settings, we don't have enough resources. So, and then the second thing is the population density and delays in treatment. So spread is always high. Yeah, because in Australia and developed countries, when people with a cough go to a pharmacy, never get any antibiotic. If without cough, anything, they always give any symptomatic treatment. If they identify, always they send to hospital or TB treatment centers. But in developing countries, it's not happening. That is the problem. So most of the time, one patient with a presumptive TB come to the pharmacy, and we start to, pharmacists start to give antibiotic, and we are delaying. That person go to the community, spread the case. But it is not a case with the developed countries. The system is well regulated. So there's a lot of problem with our system, resources, economy, of course, because we need money to do all these things. And we can't blame anybody, because the pharmacy setting, the wages, salaries, and all these influence. So we have to come up with a proper framework in developing countries in order to eliminate or minimize the new cases, incidents, and future spreads.
Thank you, sir. Sir, in India, if we see that the government having a lot of initiatives, like there is a direct treatment service to the patients.
Yep.
And if anyone get affected by TB, and they have to submit the data to the government officials, and the private hospitals or private pharmacies should not give the TB medications. Yeah, or if they are giving TB medication, and that statistics should be forwarded to the government, and thereafter the government will provide medication directly to the patients. Like that, there are a lot of initiatives are there, sir.
Yeah, that is
But
highly
still, if you see,
recommended.
there are a lot of cases of TB is there.
Yeah.
So
yeah, initiatives are there, but how implemented and enforced?
Yeah, it has been implemented, I think so, sir. Drug inspectors, they are collecting data regarding the TB medication selling, and the local primary health centers are collecting data, and the village health nurse will delivering the medication every day or weekly once regularly. But still, there are a lot of TB cases are there. Any factors that has influenced this?
Again, any? Sorry.
If any specific factor like that environmental conditions.
Yeah, one thing is like, you know, from my reading, what I understand, the TB spread or community transmission is high before treatment gets started. But according to literature, again, it says, so number one, the TB transmission is very high before treatment gets started. And according to statistics, it says always in developing countries, including India, delays in detecting these TB cases, because I can't blame anybody again. India is one of the highly population dense country. Population density is very high, and rural settings are there. Though we are, you know, the government and the other organizations are initiating a lot of things, but it's still people, you know, they may not care. And we did some stigma study in Vietnam. They kind of fear, or they think like, if I reveal like I have a TB, then there is a problem, because they think socially I won't get a job and people will not take me to the job, this and that, so they will not reveal. Then I can relate this one into low income setting. For example, like in low income setting, if people lose their job, what will happen? So because of TB, then they may not come up and say, I'm having this problem. So there is some issue in developing setting. How we can really deal with this is an issue. One of them is poverty or economic status, and then population density. These are the issues we have. Due to population density, spread is high. Poverty, people are not coming up. People are not willing to go for testing or anything. They just want to live with it. Or, I mean, this is, I'm talking about Vietnam cases. So probably the same thing would be, yeah.
Thank you, sir.
No problem. Yes. Any suggestion? Any question, please?
Any other questions, please?
Okay,
And
sir,
if you are interested, you can still communicate with me through email. This is my email address. And yeah, I'm happy to, maybe if you have any collaborative research ideas, yes, I'm happy to contribute. Or if you want any guidance, or maybe future higher studies, anything for students, you're more welcome. Drop me an email. I'm very happy to reply your queries.
Thank you, sir. Thank you for your sharing, sir, for your email. I hope this interaction, sir, will motivate the students and encourage them in active learning of. Can you hear, sir? Can you hear?
Yeah. I'm hearing. Yes.
Encourage them in active learning of community pharmacy. So
Yes.
on behalf of our management of AKCP, Arulmigu Kalasalingam College of Pharmacy, hereby I express my wholehearted thanks to you and your esteemed university for giving such an informative and wonderful presentation about the community pharmacy. So some seeds of intelligence in our students, sir. Sir, thank you, sir. Thank you, Dr. Shukry, sir.
Thank you so much having me in. Yes.
Thank you, sir. In future also, let's have a good collaboration for the development of our students' career, sir.
Yeah, of course. I'm very happy to share with that. We have some collaboration with Vietnam, Indonesia, also Sri Lanka. Of course, we can have collaborative research, as I mentioned. Yeah, we can keep in touch in the future. And of course, the students, if they have any ideas, they are welcome. Yes, please. Thank you.
Whenever would like to plan to India, sir, in future, please let me know, sir. We'll arrange. We will invite our institutions.